Hi, my name is Emma Walker. I am going to be discussing my DNP project, which is titled Teach Back Education During Emergency Room Discharge, Decreasing Repeated Emergency Room Visits. These are my committee members. I have my faculty chair, my 705 faculty, and then my community member of Dawn Knotts. So project aims or goal of this project. So the question was, in patients who discharge home from the emergency room, does the implementation of Teach Back education during discharge teaching decrease repeated emergency room visits when compared to patients who do not receive Teach Back education at the time of discharge from the emergency room? So the goal of this project was to decrease repeated emergency room visits through the use of Teach Back education by increasing health literacy levels to promote self-management of illnesses and proper follow-up with a primary care physician if indicated. So some background information. What is discharge information and why is it important? And how does it affect workflow? So discharge education is the education given when a patient is leaving the ER to go home. Discharge education includes information such as diagnosis, treatments, medications, follow-up care, and red flags that would indicate a patient needs to return to the ER or go to their primary care for further follow-up. This information can help dictate how patients take care of themselves. Like I said, so either following up in the ER, following up with their primary, taking their medications, any new diagnosis, things like that. Lack of education does increase disease progression due to either lack of medication compliance or lack of self-management. One study I used found that anywhere between 17 to 42% of providers do not give enough education when leaving the ER. So patients who do not understand their discharge instructions or who do not get complete discharge instructions have a risk of an increased repeated emergency room visits, hospital admissions, and medication errors. So the lack of education not only affects the workflow of the ER, it also increases morbidity and mortality rates for patients, and they're at increased safety risks when they return to the ER. Readmissions are harmful to the flow of the emergency room, which also increases safety concerns for patients, because if the ER is overworked and understaffed and there's an extra amount of patients, you're running the risk of errors there, or if wait times are increased, decreased patient satisfaction follows that. The overall workflow of the ER is bogged down, and this can just increase the risk of error simply due to human nature, either with staff, with patients, waiting for care that they need, all can be detrimental to the patient and just overall frustrating for the ER staff. So what is Teach Back education and how does it help? So Teach Back education is when a patient places the discharge information in their own words and then tells it back to the staff. So in this scenario, the provider will give the education and then ask the patient to describe that information in their own words. So the goal of this is to be able to find gaps in the information that would require further education and to ensure full understanding of the instructions given to them. So when you're asking a patient to teach it back, you can kind of see, did you fully understand this, or are you confused, or did you understand this incorrectly? And then that gives you a chance to go back and correct the information. Teach Back education has been proven to increase understanding and retention of discharge instructions and increase the self-management of illness, which is the entire goal of this project. So what does the literature say? So through this project, we study lots of different forms of literature. So what I found was that a majority of patients do not receive adequate education during their stay in the emergency room. So that's how we established that this is a problem. And then Teach Back education has been proven to increase the retention of information, and patient's time of discharge is proven to be the best time to provide education to the patient. So what this means is we know that patients are not getting adequate information. We know that they're not getting everything that they're supposed to. We know that discharge time is the best time to give this information, and we know that teach-back education has been proven effective. So even in a busy environment, staff found that teach-back education was beneficial. Staff using teach-back education found that using a structured educational tool helped improve staff's confidence in providing discharge education. So teach-back is a structured form of education. It gives staff kind of like a little bit of a prompt to follow whenever they're doing education, things like that, and how important it is to make sure that we're getting all of the information needed to the patients. So all of the studies used in this project had IRB approval. They were all reviewed in their original states. There was no concerns for like fraudulent materials. There was no conflict of interest, and all of them, followed HIPAA rules as needed. So overall, the review of literature that supported this intervention was strong. It is a pretty low risk intervention in general. So to have this proven information in the background that says, yes, it has been proven to fix a problem that a lot of emergency rooms are here. And that really helped me prove that teach-back education was worth a shot. So what was the theoretical framework of this? I used Lewin's change theory, which is 3 steps of unfreezing, moving to a new level, or the change process, and refreezing. So unfreezing is letting go of the past policy. So for this project, it was realizing that the current discharge process was not effective, and therefore there needed to be a change. So this facility didn't have a set discharge policy. Sometimes providers were giving it, sometimes nursing staff was giving it. Providers were supposed to, but weren't always. There wasn't really a checks and balance there to make sure of that. So the first step of this was to acknowledge that, yes, we have some sort of, plan right now, but no, it's not working. We're still having these repeated emergency room visits. Patients are still not fully understanding their discharge instructions. And so what did we need to do? We needed to go on to the second phase, which is moving to a new level or changing. So after the education process of, what is teach back? How can it be beneficial? What are your concerns? What are not your concerns? We were able to implement that project into place. So this is when we moved to the new level of implementing it, trialing it, doing the study to determine whether or not teach back was effective in this location to prove or to reduce repeated emergency room visits. The final step is refreezing. So this would be creating a new protocol or policy to implement the intervention long term. So for this project, it would be creating a new discharge policy that states that teach-back education is a requirement and an expectation of providers and nursing staff when discharging patients from the emergency room because it proved to be beneficial to the patients. So those were the steps that were used to back this project, and the goal that it had was to create a new policy or procedure to protect patients and promote discharge education. So how did I do that? So my method and design of this project, it is a quality improvement. Information was gathered through a retrospective chart review, pre and post intervention. So in order to do this, I ran an automated report in the electronic health record, or the EHR, that this facility uses. This report allows us to determine the number and which patients came to the ER during a time frame. It allowed me to even just narrow it down by age, make it selective, which made the data collection process really easy. So the first test I ran was from August 1st through August 31st of 2024. And this, I ran 2 total reports. The first report was the total number of repeated ER visits that met my inclusion and exclusion criteria. And again, I was able to filter that through this automated report. And then the second one I ran was the number of repeated emergency room visits that met inclusion and exclusion criteria. So that was the pre-data that I collected. The project was implemented from September 1st, 2024 through October 31st, 2024. So a total of 2 months of the implementation process of this project. Staff was educated prior to implementing on what Teach Back education is, the benefits, how it would look in the clinic, through email, staff meetings, and then a provider meeting was all completed, just discussing the project prior to implementing it. Any questions that a patient had or staff had, was answered during that time. So the post information was the exact same reports. So it was the total number of ER visits that met pre and post, or that met inclusion and exclusion criteria, and then the number of repeated emergency room visits that met inclusion and exclusion criteria was run again from the dates of October 1st through October 31st of 2024. So during that second month of implementation, I chose the second month because I wanted to allow a little bit of a grace period with that first month for staff to kind of find their footing, to get into a groove, and to discover a new routine of understanding how to give it and to come up with any questions or concerns that they had. So I ran it through October 1st, 31st, the second month of the program, to get better information. So after this, the total number pre and post and the total number repeated pre and post were given. I met with Maryville statistician, and this information was then placed into a lower tail z-test to determine statistical significance. So what was the sample size? So pre-intervention, I had a total of 613 ER visits that met criteria, and a post-intervention of 577. This is a strong sample size. When I met with the statistician before implementing the project, I needed a total of 154 pre and post visits total to prove statistical significance. So I had a very strong sample size that this was able to run over. So pre-intervention, there was 13 repeated ER visits. Post-intervention, again, 13 ER visits. You can see there in the graphic, kind of explaining very close sample sizes for both pre and post. So not a huge difference found, which we'll discuss here in a bit. The importance of this sample in this setting is that it is a very small rural health ER. They run a total of 4 ER beds, 2 trauma bays. Their regular staffing is 2 RNs and an ER tech per 12-hour shift, and then a 24-hour provider. So while the change, or when you see the repeated visits, you're like, oh, it's only 13. But 13 repeated visits in a ER this small can be very significant for that staff and for the way that their, facility runs, things like that. So when I gave that to the statistician, we plugged it into the lower tail scale. So the statistical test of a lower tail z-score is used when you're expecting a decrease in a number, such as for my project, a decrease in repeated ER visits. So when I met with the statistician, he was like, I think this test is the best. We looked it over, and I agreed, that we were hoping to find a decrease in numbers to prove statistical significance. So after we plugged in all of our information, we got a p-score of 0.5620, which in layman's terms means that I did not discover a change. So in order to be statistical significant, it had to be less than the 0.05. That is where the grounds of change was found, and mine was bigger than that. So I was unable to reject the null hypothesis, and no change was to be noted to be significant. So essentially what that means is I did not create enough change with the intervention to show a change in the numbers. As you saw in the previous slide, the sample sizes were pretty close. The total number of visits was pretty close. The total number of repeated visits was the exact same. So I wasn't able to show a reduction in the repeated emergency room visits. Therefore, I was not able to prove my hypothesis is true, that teach-back education decreases repeated emergency room visits. So this project was technically unsuccessful in the aims that it had, based off the statistical information that we gathered and were able to determine here, which was unfortunate and frustrating. There were some limitations to the process, and we'll discuss those now. So some of the major limitations were, during this time, I had a management turnover. So this project was designed with the previous manager. I met with her. We discussed multiple different project options when I was starting this process. And she was really interested to see if there was a way that we could do better discharge information, but also decrease repeated emergency room visits. So we kind of took on that research project together. She was with me from the beginning, and then unfortunately she stepped down and a new manager took over right about the time I was supposed to be implementing. So I had to repitch the idea to the manager. The new manager kind of discussed where we were at. It actually delayed my project pretty significantly in the implementation stage. Had to kind of bring her on board with a little bit of extra education. But I think that at that time she wasn't seeing the same significance or importance of reducing these emergency room visits. And so I think that led to the other limitation of some staff motivation. So during this time, with the new management, there was a lot of changes in policy and rules. And I think it was just a lot on the staff to also throw in my project as well. I believe that the constant change in the rules and in the policies, staff was confused in trying to make sure that they were doing everything appropriately, and that my project necessarily wasn't a priority for them. And I think that was part of the issue of making sure that compliance was done and that teach-back education was done. It was encouraged and enthusiastic, and I didn't ever want my project to feel like a burden. And I worry that with all of the changes that maybe that's what had happened to the patient. So because there was no huge statistical change, we were unable to create a policy for long-term use of teach-back education. So further research is needed. There was some good things for practice. So it was easy to implement. It was inexpensive. It didn't cost really anything. I had some studies in there that are proven that it didn't add any additional time to the discharge process. And so it really was budget friendly and easy to implement, and it encouraged good baseline patient communication and teaching. So I felt that it was good practice in general. But because we weren't able to prove that change, there is further research needed. So it is a good starting point for more research. We proved this inexpensive, easy to implement project didn't work. So now we need to look into something else. Maybe that would kind of advocate for some more budget changes, things like that, to implement a more expensive project if needed. But I do think that it did provide a good starting point. Maybe we just need to find some more ways to encourage, or more of a way to make sure that it was getting done appropriately, things like that, and further research could have been completed there. So in conclusion, repeated emergency room visits are damaging to the ER workflow and an increased risk to patients. Teach-back has been proven in literature to increase health literacy levels and decrease emergency room visits. This teach-back was implemented at the time of discharge in a rural ER, but we were unable to reduce repeated emergency room visits with teach-back alone. So I genuinely enjoyed this project. It helped me learn and stress the importance of health literacy levels in my practice. I think that if I was to do the project again, I would probably implement simplified discharge education. So this would be something like a single sheet that takes the whole discharge packet and summarizes it into that sheet. So like it would say what the diagnosis is, what the treatment is, did we change your meds, do you need to follow up, and when. And staple that to the front of the discharge instructions so patients don't have to cycle through the whole packet to get the information that they're needed. I think that maybe that would, on top of the teach back education, help increase health literacy levels and decrease the follow-up or the repeated emergency room visits. This project did help me as a provider. It helped me really focus on making sure my patients understand the information that I'm providing to them, to allowing more time for education, and to just really not assume anything about my patient's health literacy level, because just because their, intelligence is high or they're the CEO of a company, they may just not understand healthcare. And that's okay. That's my job. I understand healthcare. So doing this project really helped me remember to slow down and to do that. I do utilize teach back education if I'm giving new or complicated information. I also use this for patients who are just having a hard time understanding anything I'm teaching them. And I have found it pretty helpful in my education as going through clinicals, and even as a nurse right now. I think it could have a large impact on patient teaching. The DMP program here and doing this project has made me really appreciate and think about evidence-based practice more. I think when you have to put your own work into an evidence-based practice, you appreciate everything that previous researchers and future researchers do to make sure that we are giving factual information to use in our practice. We see the hard work and the effort that they put into these articles and things like that. And I think this really gave me a good appreciation for all of the information that's easy at hand. So for my references, I have this QR code. You're welcome to scan it. It'll take you to a Google link. I found that was the easiest way to present all of the information and all of the references that I had here. If you have any questions, please reach out to me, through my Marybelle email as needed. I really have enjoyed doing this project, and I hope you enjoyed learning about it. Thank you.